group part 1 and part 2. Next Thursday will be part 2, and that's where we're going to be talking. We're going to touch on them a little bit today. Some of the various abnormalities that you'll see in the patient population, things that basically have sequela throughout the body, okay? But their main issue is going to be cardiac ramifications. So we'll touch on some of those diagnoses today, but we'll talk more in depth about those disease processes next week. And also today, just to make you feel real uncomfortable, we're going to do an OSCE at the end of class, and I'm your patient, and we're going to learn how we present a patient, okay? Because moving forward in your next OSCEs, you will actually have to regurgitate that information back to your professor and basically give a presentation of your patient, okay? So we're going to do that today, and it's nice and gross. Okay. All right, so we're going to review cardiac anatomy. We are going to review the cardiac exam for a normal patient. Okay, some of that's going to be ad nauseum. I notice you guys all know what a normal patient looks like, but we're going to talk about it again. Looking at bedside skills in terms of history, getting a good physical exam. Looking at ischemic chest pain. So these objectives cover both lectures. So ischemic chest pain and other cardiovascular diseases, we're talking about that next week. Things associated with dyspnea we'll be talking about today. Basically, how to identify different cardiac murmurs. So part of that is going to be talked about today. Some of that's even going to be incorporated into next week's lecture and next week's lab. Understanding abnormalities of other parts of the body. So we'll review those again today. Most of those pictures should be familiar because they're going to be stuff that you would have seen in the eyes, for example. We're going to talk about various diagnostic studies that we use to aid in delineation of various cardiovascular diseases. So we'll start touching on those. So when Professor Sparker actually gives all of her cardiac lectures, it's not completely foreign to those of you who don't have any health background, okay? Well, you have this health background now. So we look at the external structures of the heart, okay, just always remembering where our ventricular structures are, where our atrial structures are, pulmonary artery, superior vena cava, aorta, kind of how that is located and tilted just a little bit to the left-hand side on the chest. And then, of course, remembering where all of our valves are within the heart, because they definitely go along directly with what we hear and when we hear it, and why we hear it better, say, at the base of the heart versus at the apex of the heart. Okay, and remembering that things are kind of reversed. Your base is actually at the top, apex is actually at the bottom, so it's kind of flipped upside down. So just to review vital signs, because I think everybody kind of breezes over vital signs, and I know we didn't even discuss this when we talked about pulmonary. When we talk about vital signs, so we always talk about temperature, respiratory rate, heart rate, blood pressure. They even call the fifth vital sign essentially your pulse ox. We always like to document somebody's pulse ox. Somebody I had today asked for a pulse ox. I made that up, whoever asked me about that. But remember that sometimes these are dumped or populated into electronic medical records. So you are signing off on the chart. So every single time, if you have a patient who's in the ER, for example, and they are on continuous monitoring, maybe every single time that blood pressure cuff goes up, sometimes they electronically get dumped into your chart. Or sometimes your nurse will come by and tell you, hey, by the way, respiratory rate's 24. And you're like, got it. By the way, respiratory rate's 24. And what they're documenting on their side in the nurse's notes, which aren't necessarily readily visible to us unless we click on review nurse's notes, is I've notified the PA. I've notified the PA again. I've notified the PA for the third time, okay? So you always want to make sure that you're looking at that because you're eventually signing off to say, yeah, I reviewed the nurse's notes, okay? So you need to make sure that you're documenting it. We never want to say VSS, vital signs stable, because even a dead patient has stable vital signs, okay? As one of my first bosses says, all bleeding eventually stops, right? Basically, eventually the patient will just have no pulse. But that is stable. If they had no pulse 5 minutes ago, and now they still have no pulse, shockingly, they're still stable, okay? So you gotta make sure that you're actually documenting what you're finding. So we talk about a fever, we always like to talk rectally, so typically your cutoff is 100.4 rectally. When we talk about oral temperature, 99.5 is considered a fever. I honestly consider more like 100.5, but you always have to reference it back to the patient. So did the patient just drink a hot cup of coffee from Starbucks? Did the patient just eat a popsicle and now you're taking their oral temperature? So that's where oral temperatures can kind of throw you off because it can be a little bit swayed by what the patient may have just drank or eaten, okay? Remember, for the very young and for the very immunocompromised, you want to make sure, like your cancer patients, for example, your threshold is significantly lower with regards to temperature. You're worried about the 100 in the patient who's just finished chemotherapy. You're also worried about the rate of rise. Sometimes it doesn't necessarily, not that it doesn't matter that a child's temperature is 105, but in terms of if they're going to have febrile seizures, it's a difference in how quickly they got there. If they rose really quickly, they're more likely to seize. If they kind of steadily rose over the course of several days, less likely to have that febrile seizure. So you not only want to know what the temp is, but how fast it got there, especially for your peds patients. In your adults, if they have a high temp, we always jump to infectious causes, but you want to think about other things, so you think outside the box. So the mnemonic time is what you use, okay? So you think about toxic issues. We always want to think about infection. We think about metabolic issues. One example would be thyroid storm. Most patients don't, thyroid storm is not that common, but they could be very, very hyperthyroid on their way to thyroid storm and essentially present with an elevated temperature. We talk about environmental, very common for here. We want to think about heat stroke, okay? So the person who's kind of been in a hot car, the person who's just been outside in the summer for too long, may actually have heat stroke as a cause of their elevated temperature. We talk about respiratory rate. Remember, respiratory rate for an adult is 12 to 16. If we always see it documented as 20 in the chart, it's just because A, we don't count for 30 seconds, or B, we're horrible at math, okay? So you don't want to count for 10 seconds and multiply it times 6. You want to make sure you count for a full 30 seconds. Bob is laughing at me because people do that all the time, don't they? Respiratory rate 20. If they even count. Rise and fall, looks good. We'll call it 20, okay? 20 for an adult is actually considered a little bit high. And it makes a difference for the patient who's 20 and really breathing deeply versus the patient who's 14 and nice and calm. Okay, so you don't, even that small difference in terms of respiratory rate, that's just one extra breath per every 10 seconds. And all of a sudden you've got a 20. Okay, so make sure that you count accurately. Make sure you look at how they're breathing. So are they breathing too quickly, breathing too slowly, breathing very, very shallow, breathing very, very deep? Does it look like they're in any distress with their respiratory rate? You want to note all of that in terms of your clinical findings. We talk about heart rate. So typically, technically tachycardic is considered over 100, but the majority of adults shouldn't walk around with a heart rate in the 90s. It's just not that common. Most adults, even with like a litany of medical problems, they can be a COPD or a diabetic and they have one heart attack, and their heart rate will be 82. Okay? So it really shouldn't be ridiculously high. Remember, when you're young athletes, any athlete for that matter, in very, very good shape, they will have a resting heart rate typically in the 50s, okay? I remember one time the alarms were going off when I was in the hospital because my heart rate when I slept dropped down to 38. They came and woke me up. They'll never wake me up. Bad day for that nurse. I'm like, dude, I was finally sleeping. That person does not need to be in the ICU. Conversely, your pediatric patients will have a higher heart rate. That is just normal for your pediatric patients. We all remember, maybe we don't remember. But if you've ever watched any TV shows, and they put the heart rate monitor on the baby, the fetal heart rate should be like 140, 160. It should be crazy fast. So pediatric patients will have a higher heart rate. It does not mean that they need the pediatric ICU. That is normal for them, okay? Again, always in the context of your patient. When you're feeling for a pulse, it's really nice when you're counting that pulse. If you actually have a pulse at the radial artery, you at least have a blood pressure of 90. So it's kind of nice when you feel that blood pressure, you feel in their wrist, they can't be that bad because their systolic blood pressure is at least 90 if it's palpable there, okay? Look at their medication list. Beta blockers are notorious. Beta blockers are typically for hypertension, but some people will actually take them for Parkinson's disease because they are fantastic for tremor. Some people will even take them for essential tremor. The 88-year-old woman, and you look at her and her head does this all the time. You look at her med list, she's taken propranolol, betcha, okay? But beta blockers prevent your heart rate from getting higher. They will never get tachycardic if they're actually taking their drug. Okay, so don't necessarily look for, well, they weren't tachycardic. They're not going to get tachycardic. Okay, their drug is preventing that cause, or preventing that ramification. We talk about blood pressure. Anything in an adult 140/90 is considered quote-unquote hypertensive. Always remember to look at your blood pressure in the context of your patient. Your patient comes in and they have an open femur fracture. I would expect their blood pressure to be high, okay? Because they're going to be high because they're in pain. So always reassess your blood pressure. Make them sit down. There's this concept called regression to the mean, which means even if you go in and someone's blood pressure is very high when you're first seeing them, maybe because of white coat syndrome, maybe because they just hate going to the doctor, if you let them sit there and you kind of distract them and you let them relax, they will regress to whatever their mean is. Their mean might still be high, but don't just treat that first number. And don't ever treat a number. Treat your patient. Okay? So look at what your blood pressure is telling you in the context of your patient. Yes?
Isn't there some big push to lower our threshold for hypertension right now?
Oh, yeah. They want to get everybody to like 80/70. You know? Or not 80/70, sorry. Maybe I need more Diet Mountain Dew. They want to get everybody to like 120/70. You know? The problem is, when you look at the elderly population, it's kind of like a badge of honor. If you're sitting around, walking around with blood pressure of 170 or 150/90, it might need to be there to, I don't know, perfuse the brain, kidneys, just saying, okay? So don't force everyone's blood pressure low because you're just treating a number. The goal is end organ perfusion, and some people need that higher blood pressure for end organ perfusion, okay? Some people are starting to understand that yes, if we have crazy hypertension in a 27-year-old that's untreated, completely understandable. Yes, are they going to get blind if you don't do anything? You betcha. Are they going to go in end-stage renal disease? Of course they are. But on an 85-year-old patient whose blood pressure is a little bit higher, labs look decent, seriously, how much longer are they going to live? You know? So don't drop their blood pressure just to treat the number, because actually what we're causing is more heart attacks and strokes because we don't have end organ perfusion, okay? Always remember proper cuff size. Remember, if we've got a cuff that's too small, we're actually going to get a blood pressure that's 10 to 30 millimeters of mercury higher, versus conversely, if we have a blood pressure cuff that's too small, you know, you sit there and you put it on and you're like, if you listen to the automated machines, it just goes like forever before it's right? Yeah, I'm a little tired today. Okay, if you do that, then you're actually going to get a blood pressure that's lower than what you should be getting. So always make sure you have the proper cuff size. You know, then you put the one on, and it's like, and then it's like, the Velcro's ripping off, you know? That it's like it'll pop across the room. The blood pressure cuff is probably too small, okay? So make sure you're using the proper cuff size. Unless you ask my dad's like, they always use the wrong cuff on me. I'm like, no, you just have high blood pressure. Does that mean I can come off my drug? No. All right, so cardiac exam, we want to do the same exam, the same way, all the time. Whenever you do a physical examination, you want to talk about consistency. For some of you who had, you know, some of your different OSCEs today, you basically found things that you could have found a different way, but because you kind of got used to doing it step by step and systematically in physical diagnosis, you caught on other findings which clued you into a different diagnosis than maybe you were going at to begin with. So just get in the habit of kind of thinking through things in a very systematic way, okay? You always want to, you know, palpate, inspect, palpate, percuss, and auscultate. You always want to use two senses, so you want to be kind of listening to the heart as you're auscultating it, feeling for that pulse. I'm not a big fan of palpating the carotid arteries, okay? I've seen way too many plaques on the inside. And typically that's what, you know, when we talk about carotid maneuvers to kind of break an abnormal rhythm in a heart and kind of get people back, we don't do that anymore. Why? Because we were causing a lot of strokes, okay? So you can feel the carotid pulse, but don't sit there and rub on it. I mean, you guys should all be healthy, but your 85-year-old patients won't be, okay? I even get nervous when I go and have a massage and they rub my neck. I'm like, It's okay. Please don't. So remember when we talk about our landmarks, our aortic, our pulmonic, we have Erb's point. Remember Erb's point, we've got a different one that we'll talk about later with regards to the neck. So that dude had a couple different areas in the body named after him. Okay, so there's a couple different points that are called that throughout the body. The mitral and tricuspid valve. So we talk about the review. So we position our patient. Most of the time we have them in 30-degree angle. Okay. We can also turn them to the left side, left lateral decubitus. We can sit them upright. We can sit them upright, have them lean forward and exhale. If we want to exacerbate certain heart sounds, most of the time we're going to be on the right side of the patient to examine the patient. Honestly, that's primarily because if they're going to roll to the left lateral decubitus, you don't want to be like, hey there, how's it going? Okay, it's standing right in front of them. It's much more comfortable to drop the bed and reach over them rather than just be like literally right in their face, okay? If you ask one of the second years, she actually had to sew up the inside of somebody's mouth the other day, and she was just like, please just don't breathe on me, okay? So this is why the patients stop breathing on you. They don't all have the best hygiene. Just saying. So we want to inspect and palpate, so we want to start at the center, the second intercostal space. Note the diameter, we want to note the location amplitude of the apical impulse. Sometimes that's the point of maximum impulse, sometimes not. Okay, sometimes they correlate, sometimes they don't. We'll talk about that today. Tangential lighting, if you're really trying to look for any heaves or lifts, sometimes that will help you along that path. We want to percuss the cardiac size, so we'll talk about that today because it kind of gives you a ballpark on kind of how big the heart is and maybe where the heart might be displaced to. Got to think about patients who might have a hiatal hernia, for example, where part of the stomach is up in the chest cavity. It's certainly going to displace the heart. So we're going to auscultate for heart sounds and murmurs with the diaphragm and the bell. Always remembering we don't want to push too hard on the bell, because if we do that, we've basically converted it to a diaphragm. Then, what are you doing? You might as well not even switch it around, okay? I'm hoping that in this, some of the heart sounds actually show up. I was working really hard this week, and it was really fun at my house. To record it from my iPad to my phone, to then import it into the PowerPoint. It should play on yours, but I couldn't get the audio to come over this today. But it should play on your PowerPoints for an S3, S4 gallop. So we talk about left lateral decubitus. We're going to auscultate there more so for diastolic murmurs, again with the bell. When we have them sit up, we want to inspect the pericardium because sometimes you'll see some additional heaves or lifts in that area, especially at the base of the heart, again at that upper aspect of the heart. We want to palpate for the apical implex. Again, that should be sometimes your point of maximal intensity of the heart. Not always is that your PMI, depending on if you have particularly right ventricular hypertrophy. So we want to auscultate for the heart sounds, for murmurs. We sit them up and lean them forward. Primarily, we're listening for those diastolic murmurs, and again, we want to listen at the top part of the heart, the base of the heart, okay? So when we palpate, again, we're palpating around the chest wall. We're feeling for any heave or lift. You really want to start with using the palm of your hand, so right over the heads of your metatarsals. And as you're placing it down on the patient's hand, you should feel, if there's anything there, you'll feel it vibrate out through your fingertips. And that's kind of how you get your best tactile sense. Always knowing that in terms of imprinting to the brain, your thumb and your pointer and middle finger kind of give you the best tactile sense, so that you're going to feel the vibrations more so through your second and third phalange, okay? So we want to palpate around. Then we want to go to the apex of the heart, look for the PMI there. You can also sometimes appreciate an S3 gallop there, even on palpation, before you'll hear it on auscultation. If we're up at the pulmonic area, we might actually feel a systolic impulse if we have really, really bad pulmonary hypertension. So up in the upper aspect of the heart, we might appreciate that there. So again, this apical impulse or the PMI, not necessarily the same thing, but in most healthy patients, it should be. Where you feel the pulse the best should be at essentially the apex of the heart, okay? But not always. So we want to look at the medial to the midclavicular line, fourth, sometimes fifth intercostal space, sometimes fourth. I always think it's right below the nipple line, and if you were to put a bra on, it would be right as your bra line. Okay, always a good kind of point to start, especially on women, because that's kind of about where it should be. So you can get it displaced to the epigastric area if we have COPD. So if we have kind of that barrel chest, enlarged lungs, kind of look to feel for the apical impulse a little bit more medial than you would anticipate. Stacy? Well, what did I do? There we go. If it's larger, so typically it should be maybe no more than really the end of your finger, because typically we always want to get it down to one finger when we're palpating for it. So if we have larger, if it's displaced, if it's more forceful or longer in duration than we anticipated, then that could be an issue with regards to cardiac enlargement, okay? Sometimes it is related to the size of your patient. So sometimes if your patient is just more narrow, if their front to back, their AP diameter is just a little bit more narrow, you might appreciate that pulse a little bit stronger, not necessarily indicative of any underlying cardiac disease. So again, your apical impulse and your PMI may not always coincide. You always want to think about right ventricular enlargement, if that's the case. Okay, so you want to make sure that you're kind of, where's the point of maximum impulse, but where's the base of your heart? That might actually be in two different spots. So if we talk about actually palpation of the apical impulse, we can feel that when the patient's upright. Left lateral decubitus is typically easier to feel it because you can kind of have a roll away from you. Again, you're standing on the right side, so they're rolling away from you at that point. You can search for the impulse with the palmar aspect of your hand, and then you want to get it down to basically try to get it down to one finger. Because the nice thing about getting it, you can take it down to a couple and then try to get it down to one. Really to pinpoint it, number one, it gives you a good indication of whether there is underlying cardiac enlargement. It also gives you just kind of a good, it should only be one finger. It shouldn't be that much bigger. It shouldn't last for too long. If you start putting 3 fingers over it and you can really feel the pulse equally on 3 fingers, that's a problem, okay? The location of it, so again, the diameter should be only about 1 interspace. The amplitude, it should feel like something just tapping. Again, it should feel like a radial pulse. It should feel like a femoral pulse. Okay, it should be a gentle tap against your finger. If you're going to auscultate while you're appreciating the PMI, or if the PMI and apical impulse are in fact equal, then you should almost hear it through S1 almost to S2. It should be about 2/3 of your lub-dub. Okay, so we'll talk about lub-dub today, your S1, S2. It should extend through the majority of that, up to about 2/3 of it. So when we talk about percussioning the chest wall, so before you would even jump and say, well, I'm going to get an echocardiogram and I'm going to look at the size of this heart and see what's going on with the heart size, you can actually percuss the cardiac borders. You want to start high and work your way down. So you want to make sure you're going all the way up to the second intercostal space and kind of coming down. Another way is to actually start in the left anterior axillary line and move medial to where you're appreciating that difference, that change from resonance to dullness. And you want to move toward the sternum. You should be about, from the mid-sternal line, you should be about, what's Stacy? About 9 to 10 centimeters, okay? When we're talking about the left sternal border, it should be changing at about 6. So when we talk about percussing, the one way I like to do it better, if you're truly going to percuss, is actually to put your finger up and down, okay? Superior, inferior. And that way, as you move across, I think you get a better appreciation of when you change from resonance to dullness, okay? And really get a better appreciation for the size of the heart itself. You can do it down as well, and basically you can come in, because remember, of course, we've kind of got that reverse heart shape, right? So the base of our heart should be a little bit more narrow, so we should be able to appreciate kind of how close we're getting into the sternal line. But again, when we talk about our borders, the right side of our heart is bordered by right superior vena cava, the ascending aorta, and the right atria, whereas the left is the left aortic arch, the pulmonary atrial trunk, which is pretty large, and the left atria appendage. And then the inferior aspect is primarily your right ventricle. To a much lesser extent, it is the left ventricle, okay? That's dependent upon somebody having normal cardiac size, okay? So any type of hypertrophy, typically in the left ventricle or right ventricle, is going to cause that to be displaced. So we talk about auscultation. We want to make sure we always follow a very consistent pattern. And I know that you guys really did this very well in PD1. We never want to auscultate through clothing. It doesn't mean that for every single patient that you listen to, that you got to tell them to disrobe. okay? When I see patients in the ER, I just basically fish my stethoscope down their shirt, okay? Because sometimes they're there for like hangnail. Not a hangnail, but you know, sometimes they're not there for anything cardiac, but every single patient, you should listen to their heart and listen to their lungs, okay? So you want to make, so sometimes you just fish it down their shirt, but you never want to auscultate through their clothing. If you're going to listen to their lungs posteriorly, you can just go up their back, kind of lift their shirt, go up their back, and auscultate the posterior aspect of their lungs. So we want to inch the stethoscope around. Again, kind of a very sequential fashion, right? Aortic, pulmonic, Erb's point, tricuspid, mitral valves. We want to use the diaphragm to press firmly. For those, we're going to hear S1, S2. When we talk about using the bell, we're going to hear a little bit more of our murmurs, but we're also going to start to hear S3 and S4. S3 and S4 shouldn't be there, okay? So there's ways to distinguish those. If we actually hear those with the bell, we can listen with the diaphragm because you can actually get a split S1. More commonly, we hear a split S2, okay? So again, our cardinal areas, so our aortic area is going to be in the second intercostal space, right sternal border. We move over to the pulmonic side. Now we're talking still second intercostal space, but now we're on the left sternal border. We jump down, we see Erb's point. We're basically at the third intercostal space. Still, we're going to be on that left sternal border. And as we drop down even further, we're going down to the tricuspid area and then the cardiac apex in the mitral area. So just your normal spots. I like this dude, okay? So all people enjoy Time magazine, right? Aortic, pulmonic, Erb's point, tricuspid, and mitral. Just an easy mnemonic to remember that there's the 5 cardinal spots you've got to listen to when we're auscultating the heart. Certain parts of those we're going to listen to more so in the left lateral decubitus position. Certain points, primarily when we're talking about aortic and pulmonic, we're going to listen to them when we're having them sit up, lean forward, and have that full exhale, just to kind of accentuate things that we may have heard during the traditional cardiac exam, right? The laying back at 30 degrees, kind of a nice relaxed, listen to their heart. When we talk about S1, when we talk about S1, so S1 is the mitral and tricuspid valve closure. Okay, so the intensity of that is going to be softer than S2 at the base, and it may or may not be louder than S2 at the apex. Almost always S2 is a little bit louder than S1. That's always just been my appreciation, okay? Splitting of S1 actually can occur. Normally when we talk about splitting of the heart sounds, almost everybody means S2. Because S2 will split more so with inspiration, and you'll actually be able to hear 2 distinct heart sounds on some patients. S1 can actually split also, but it's very rare to hear it, okay? And oftentimes you think you're hearing an actual abnormal sound, and what you're actually hearing is a split S1. It is the lub of lub-dub, right? So when we talk about heart sounds, we talk about lub-dub, lub-dub. So it is the lub. The timing of it is the beginning of ventricular contraction or systole, okay? Everybody's seen the lovely things that they have, the lovely little characterizations they have of PAs with the little cartoon characters and with orthopedic surgeons. Oh, they're hysterical. I had to send one to my brother because, you know, he's an orthopedic surgeon, so he's like, bone broke, me fix, you know? And the PA comes in, the patient doesn't have a heart rate. The patient doesn't have a pulse. I need to fix the bone is broken. But they talk about systole. Asystole, that's the diagnosis of the patient. The patient has asystole. So the closure, it's caused by the sudden blockage of reverse blood flow due to closure of the atrioventricular valves. So the tricuspid and mitral valves are what cause S1. When we talk about S2, S2 is your dub of your lub dub. So now we've got aortic and pulmonic valves closing. So this is where you're going to see a little bit more of a split, and we hear A2, then we hear P2, okay, aortic and then pulmonic, in terms of if you even appreciate the split. You will appreciate the split. Does this actually, could somebody hear this on theirs? This should actually make a noise. Let's try this. No. Anybody hear it on their machine? I'm so disappointed. All right. So anyways, this is a sudden block of reversing the blood flow due to closure of the semilunar valves to your aortic and pulmonic valves. This is basically, the timing of it is going to be the end of ventricular systole, as well as the beginning of ventricular diastolic issues, okay? So that's going to be your S2. I really hope those sounds work when you guys get them home. I'm very disappointed if they don't. Oh well, I tried. So we talk about a physiological split. Your physiological split is your S2, and that's going to be your A2 first and your P2 second. Again, you will hear that more so with inspiration than you will with expiration. Okay, that it will essentially go back to being one noise with expiration. It's got to be a really quiet room. You got to have a really good stethoscope. They can't have any overlying wheezing going on. There can't be sirens going off in the ER. You know, if there's all that external environmental background noise, you will not hear an S2. You got to really be listening well for it. We talk about an S4 gallop. So this occurs with atrial contraction. So basically, this is where you can think you're hearing a split S1, but it's actually S4. Okay. It's heard just before S1. It's typically, it can very rarely be normal in very, very trained athletes. Okay, so like the Michael Phelps of the world, like the very trained athletes. Okay, typically this is always an indication of increased resistance to ventricular filling. So a stiffness to the heart. So it's almost always, and I mean like Dove soap, 99.4% of the time, this is going to be an abnormal finding for those patients. If it's originating in the right atrium, it's best heard over the lower left, lower left sternal border. Usually it comes from the left atria, so you can hear it in the left lateral decubitus a little bit better. Okay. So again, not a common finding in your young patients. It has to be a very trained athlete. This isn't somebody that's like, yeah, I go to the gym. I go to the gym like 5 times a week. That is not normal for that patient. Okay, very, very well-trained athletes. It can be indicative of significant aortic stenosis, hypertrophic cardiomyopathy, as well as dilated cardiomyopathy. So even if you do hear it in someone that is a very well-trained athlete, that you're thinking, okay, maybe this is normal for them, they still bought themselves an echocardiogram. Because what's the number one cause of like all these kids dropping dead? Sudden, cardiomyopathy, right? Sudden cardiac death. So sudden cardiac death can be an enlarged heart that is undiagnosed. So that's something that's easy, that when you guys eventually go out and you're doing school physicals, you can percuss the cardiac border and make sure that that 18-year-old doesn't have an enlarged heart. You don't necessarily have to do an echocardiogram on that patient or get a chest x-ray on that patient. You can find it on physical exam. Acute MI, myocardial infarction, ischemic heart disease, episodes of angina, okay? So episodes of angina, which is basically chest pain, can actually cause this to happen. And remember, chest pain doesn't necessarily mean that the labs are going to be abnormal, nor does it mean that you're going to have abnormal findings on your EKG or your ECG, depending on how you call it, okay? So you can have abnormal changes to your auscultation of your heart without having laboratory abnormalities occur or without having an ECG change occur. So you want to be listening for this. It's easy to confuse with an S1, okay, because you might think that you're hearing an S1 split. Honestly, in my lifetime, I have never heard an S1 split. So if you think that's what you're hearing, you're leaning toward it being an S4, okay? But basically what you want to do is you want to press lightly at first. If you're unable to differentiate it being a split S1, you press more firmly. Remember, we're typically using the bell, so we're almost converting the bell to a diaphragm at this point. And the S4 will disappear, and you'll basically hear the S1 split intensify. Okay, so that's one way to kind of figure it out on a clinical exam. But basically, if you're concerned about an S4, you should be concerned. Okay. S3, which is a ventricular gallop. So basically, it occurs at the rapid ventricular filling and diastole, that normal filling of the heart. It's heard after S2. So remember, it's going to be right after S2. Okay. Whereas remember, S4 is going to be before S1. And part of this goes back to the pulse of your patient, right? So if you have a patient who's sitting there with a pulse rate of 60 and they have an S4 gallop, you're probably more likely to hear that than somebody who's tacking away at 120. Because you're listening so hard, you don't even know what you're hearing. What you do know is your heart rate's too high. But even for somebody who's sitting there with a pulse rate of 95, technically that's within normal range, right? 60 to 100. I mean, it's on the high side. You may not be able to really differentiate S3 and S4 versus just being an additional S1 or S2. That's where it kind of gets hard. So it goes back to whatever your heart rate is of your patient, okay? So it usually means volume overload in the ventricle, so typically seen in older patients. This one can be normal in children and young adults. So converse to S4, which should not be there unless you have, you know, an Olympic athlete sitting in your office, which if you do, get an autograph. S3 can be there in kids and young adults, and they essentially grow out of it. Okay, so as they develop, that should go away. If they're still hanging on to it when they're older, that's a problem. So it suggests increased left ventricular wall thickness, impaired relaxation, increased resistance to filling. They're basically not getting enough blood out of their heart and into their heart to be able to push around. So again, there we're talking about end organ issues, not getting enough oxygenation. Can be a very early sign of heart failure. If you have a reversible cause of heart failure and you treat them, it will go away. If it progresses and it's persistent, it's very indicative of the morbidity and mortality of the patient. Okay? If despite all your treatment, that change is still there, they still have that gallop there, the life expectancy on that patient is decreased just by that one clinical finding. So when we talk about S4, you can think of it as lub dub dub, Kentucky. Okay, it's the center of that you're going to hear more. S4 is going to be more distinct. Okay, whereas when we talk about S3, basically the heart is restricted and we're trying to get its impaired ventricular filling, so we're trying to slosh blood into the heart. We think about Tennessee. So we're so much better if those heart sounds work. Anyways, you'll hear them next week, I promise. And actually S3 and S4 can both be done on Medi. So you'll be able to hear both these heart sounds and abnormalities on Medi, and what we'll do is we'll really slow the heart rate down so that you can hear it distinctly, and then I'll speed the heart rate up so that you can hear the difference, okay? Bob, you're in charge of reminding me about that.
Okay.
Noted. Okay. All right. We talk about systolic clicks, so you can have many or you can have just one or two, okay? They don't have to necessarily be a whole sequence of clicks, but typically they result from an abnormal halting or prolapsing of the mitral valve is where you're so this is a prolapse and typically a regurg that we'll hear. Okay, it's not just everybody says, oh, I have a little bit of mitral valve prolapse, and their cardiac exam will be normal. Okay, mitral valve prolapse is very common, especially in our female population. Mitral valve prolapse, where we actually have oscillatory abnormalities and regurgitation of blood flow back into the chamber, that's a different story. That's somebody who truly has a problem. Okay. So it may be, again, maybe a single click or a series. When we listen to the patient, we want to listen to them standing as well as squatting down, because we are going to exacerbate that symptomatology when they squat. Okay, so you actually want them to tuck down and continue to listen to their heart, which means you got to tuck down with them. Okay. When we talk about a clinical history, a couple more slides, then we'll take a break. We talk about a clinical history. We always want the patient to express what's going on in their own words. Always remembering that your female population, and particularly if we're going to get a female, elderly, African-American female population, they didn't read the textbook, okay? Women don't come in and say, I've got pressing chest pain and it's right here. Boys do that, okay? Women come in and say, I just don't feel right. My favorite chief complaint, I just don't feel good. I'm feeling a little fatigued. Who doesn't like that one? You like fatigue?
Love it.
Loves fatigue, okay? I just don't feel good. You get your African-American elderly female, and they're like, I just don't feel, something's not right. And they're having a heart attack, okay? And your first thing is to kind of dismiss them maybe, because you have to look at the whole person, rather than the guy who comes in and says, it's right here, it goes to my jaw and goes to my left arm. Thank you, it's an MI, okay? Men are much easier in that regard. Okay. So you want to watch for facial expressions. We want to make sure we watch their hand and body movement to see kind of how they're moving. Again, is this somebody that you're noticing just the minute you start talking to them that they have a little bit of a hand tremor, and all of a sudden you're looking at, okay, well their heart rate's only 62. Ooh, but that med, they're on propranolol for their tremor. So they're never going to spike a high heart rate, no matter how excited or how much pain they get in. So those are things you're picking up just in your opening dialogue with the patient, okay? And don't give the patient the impression that you're hurried, or they typically will withhold information, okay? So you don't ever want to just sit there. Everybody has 50 million things to do. I love it when people tell me, I'm busy. Yeah, talk to me, okay? Tell me I'm not busy. So you want to sit down. Some of you actually did that today and yesterday, which was fantastic in your OSCE. Come in, you sit down. Remember, instantly you're giving that impression that you're there for so much longer than you actually were with your patient. And you're actually appearing, even though mentally you might be over here, you're appearing as if you're giving your sole focus to that patient, okay? Physical exam is going to provide your objective clues, but remember the majority of your diagnosis is going to come from your history. So your patient really is going to tell you what's going on with them. They're going to tell you the diagnosis. If you can't find it, you're not asking the right questions. So you got to just continue to dive more. And always remember that out in clinical practice, we all sit there and say, oh, I should have asked that, as you're like listening to the heart. So you pull your stethoscope out and say, hey, by the way, have you ever had have you been smoking lately? Or if you forget to ask about their social history, you go back and you ask while you're doing the physical exam, okay? Things will appear to you and you'll remember stuff. You just go back and ask it later. That's what we do in clinical practice anyways, okay? So you might as well get used to doing it now. Depend on your skills as a clinician and not necessarily on the patient's ability to communicate. You have to kind of elicit, try to get that information out of them. We'll take a break and we'll come back, okay?